topic of the lecture today is management of infectious diseases. Now, before we go on to the management of infectious diseases, we have to know that how did we came to learn that these are infections, these illnesses, these diseases we have, these temperatures we have, it's because of a specific infection. For that, we have to see in our historical perspective that how did we learn about it? Because before that, all we knew was it's because of the will of the God or it's because of some insidious nature. These were the two basic reasons people believed in. These are the two basic things people believed in, that whenever any person got ill, it was will of God for that person and for that person's family, or because of some insidious nature. And they will go on for praying, they will go on for breaking that evil spirit or something. So they didn't know about these infections. So when did we learn about the infections? In 1650s, germ theory of the disease came into life by Robert Doyle. Now, before that, people didn't know that what infection is or what microbes are basically and what microbes does in a person. So they didn't know about all of these perspectives. What we have now, or what we have this brief knowledge of infections right now, is because of 4 or 5 centuries of work from different scientists, from different doctors. So before that, they didn't know about all of these things. All they knew was that it's an illness, it will just go away or it will take your life. So in 1650s, for the very first time, Robert Doyle took a microorganism. He didn't even know that it's a microorganism, and he took it from the earth, he took it from the ground, and he related it to a disease, a specific disease. That's where germ theory of the disease came into the play. That these are actually germs or microbes that actually get inside of your system and cause the pathology and cause the disease. It was not appreciated enough at that time at that time. But with time, many other scientists came in, many other doctors came in, and they did their research. And in 1700s and in 1800s, what happened? Scientists got to know that okay, there's some organism, there's some phenomena due to which any person is getting ill. So they started these researches, they started all of those studies, and led to germ theory of the disease. Now, what does germ theory of the disease state now? Right now, if you ask me what is germ theory of the disease, I will tell you that the disease or illness is caused by, it has 3 basic points. I'm going to tell you all of them. First point is, every microbe causes a specific illness inside a person, right? Second point of germ theory of the disease is that it can spread. This disease, this microorganism can spread from one person to another person, right? And the third point is, for every illness, there's a specific microorganism, and that microorganism is going to cause the same illness even if it's inoculated again and again and again. It won't result in any different repercussions, in any different illnesses. So that's the germ theory of the disease. That's how it came into being. That's how the researchers started for different kind of microorganisms. They located them. They searched for their pathophysiology. They searched what will happen if we inoculate it inside a body, and what are the consequences of it. Afterwards, we went into the management of the disease. Afterwards, we made antibiotics. Afterward, we made all of those antivenoms, antitoxins, antibiotics. All of those are made after germ theory of the disease. After we acknowledged that, okay, there's a very specific organism for a very specific disease. In order to fight that disease, all we have to do is to fight that organism. Now, every organism has its strong points. Every organism has its weak points. So what we basically needed was to find those weak points and strike that organism right there. For example, some organisms cannot tolerate heat, or some organisms cannot tolerate any kind of cold. Just like that, many organisms have many weaknesses. We targeted those weaknesses, we targeted those genetic sequences, and we fought them, and we made these antibiotics and all of these drugs which we use now to fight infections. So, after germ theory of the disease, what came into the play? 20th century's various advances. In those advances, what was the basic highlight of those advances? Louis Pasteur. What did he do? He made penicillin. By accident or whatever, he made penicillin. When penicillin was produced or created, and then it was generated and it was given to all the war veterans so that they won't die because of some infection, it was a basic advancement towards the management of the infectious disease we hold very dear now. Next on, we had antibiotics and advent of vaccines. Now, when we knew that there's a specific organism for a very specific disease, what we needed to do was to find those weak spots for that organism and fight it right there. We started making antibiotics. We thought that we found out that this organism causes this, and it's present right here at which place of the body it was found, and weak spots were targeted, and antibiotics were made and created and generated, and those antibiotics killed those organisms depending upon their weak spots, and that's how antibiotics are produced. And as long as we're talking about vaccines, what happened with the vaccines? We saw that when those organisms are killed somehow or weakened, and when they're inoculated inside your body produces a response. Body produces a response to them and produces antibodies against them before that organism gets inside your body. So, immune system is already active against that organism. So, whenever in your whole lifespan that organism gets entry inside your system, you have already produced antibiotics inside your body to kill and fight that organism. That's how this all management came into the play. Next on, what happened? Elimination of smallpox. Millions and millions of people died because of smallpox. And they thought of this disease as an evil nature or some kind of insidious, and they didn't know what to do with that until the advent of antibiotics and advent of vaccines. Afterwards, smallpox was eradicated from the planet. Next on, what happened? We came into this mindset that every microbe is responsible for different kind of pathologies, directly or indirectly. Some organisms produce it indirectly, and some go directly inside of your system and cause that disease. So right now, if we are ill, what we do? We go for the signs, we go for the symptoms, we try to minimize it to a single microbe or at least two microbes, that okay, these microbes cause these signs and symptoms. All I have to do is take management for these two microbes and I will be all right. And all of that came into the play by knowing this small theory. Directly or indirectly, it happens due to a microbe. Next on, in this historical perspective, we're going to talk about some specific organisms which cause very specific kind of diseases in order to maintain that image in our mind that okay, every organism does cause different kind of pathologies. Every pathological organism, I have to say every pathological organism, because some organisms, some microbes are there which even facilitate our systems, which even help our systems in working as they are working right now. Normally, in normal functioning, those microbes are needed inside our body. We have many floras inside of our bodies which support us. So H. pylori, Helicobacter pylori leads to PUD and gastric carcinoma. PUD stands for ulcer disease, right? Next on, we have HPV associated with cervical cancer, as Helicobacter pylori causes gastric carcinoma and ulceratic disease. HPV causes cervical cancer. Then we have HBV and HCV linked with liver cancer. We all know HBV causes what? Hepatitis B. HCV causes hepatitis C. So these are hepatitis B virus. HBV stands for hepatitis B virus. And HCV stands for hepatitis C virus. Now, these are linked in causing the liver cancer. Obviously, they're not going to cause the liver cancer in the very start. They're going to cause hepatitis, and if that hepatitis is not managed properly, if the hepatitis is not taken care properly, and then it will lead to severe kind of manifestations, and that's what liver cancer is. Next on, we have 16%, about 16% of malignancies are due to infectious cause. What are those malignancies? We just talked about one. If we have liver cancer, if it's going to metastasize, if it's going to be malignant, it's one of those types, one of those 16% that we are telling here, that 16% of the malignancies are because of the infectious diseases. Next on, this escalating antimicrobial resistance. Now, a dilemma we have to face, a dilemma our whole community is facing right now is antimicrobial resistance. It's just like if we get a microbe into our system, right? Our immunity responds to it. Our immunity tries to overcome that microbe and kill that microbe and keep our body whole and keep our systems contained and sustained. Same kind of mechanisms is happening inside the antimicrobes now. Now they have finally realized that okay, we are same, or when the people and the humans and their hosts are changing, they're adapting. So what microbials are doing, microbes are doing, they are developing that resistance to those antimicrobials we're talking about. For example, if it took 250 milligram of penicillin for a specific infection to treat, now it takes 500, then it takes 750 milligram, then it takes 1000 milligram. And with time, penicillin won't work on that and won't work on that microbe because that microbe has adapted. That microbe has adapted to that antimicrobe. That's a that's an issue we're facing right now, and that happened because of excessive use of antimicrobials. We went for excessive use of antimicrobials, and not only excessive use of antimicrobials. The second basic reason was discontinuation of antimicrobials. There's a whole cycle. Whenever you prescribe a medicine, you tell the patient that you have to take this medicine for 5 days. That means 5 days because for 5 days you have to maintain that dose of antimicrobials inside your system to kill that organism. If that dose is not maintained, if a person skips one dose of your medicine, that dose is down. When that dose is down, that's when those microbes, those microorganisms develop that resistance, develop that phenomena in which those antimicrobials are not going to be effective on that microbe. So with time, due to negligence of both doctors and patients, because doctors should not have prescribed that many antimicrobials and patients should have taken and followed that regime. Both of the negligencies led to this day that we are having this escalating antimicrobial resistance now. Next on, let's see into global considerations, as this is the number of deaths in millions and this is rate of death per 100,000. So blue is number of deaths in millions. Because of what? Because of these infections. As you see here, it's like 13 million deaths in 1990s because of infections. But with time, it went down. It went down because of advent of antimicrobials, because there was a time when people used to die of only malaria. There was a time when people used to die only of smallpox. There was a time people would die only of flu, not even some hazardous disease or something like that. No, very minute diseases. People would die of typhoid. Now that we have those antimicrobials which help us fight against those organisms, which help us fight against these diseases, now the rate of those deaths are down. Now, if these are the people who got affected, rate of death per 100,000 has gone down in a very dramatic manner because of the advent of antimicrobials. And it's going to keep going down until or unless we don't get any backup for this escalating antimicrobial resistance. Next on, this is a graph showing global deaths all over the world. Now, if you see, all of these blue areas cover 10% of these areas, or 10% of these global, 10% of these deaths these areas which were subjected to infections. Only 10% of the people living in these areas died because of infections. As you can see, these areas which are in 30% range, now these areas are subjected to death because of infections up to 30% of their total deaths. Now comes the 40% areas in which these areas where sanitary and all of those germ theory diseases and all of those theories were not into play. They were not developed, they were not civilized. So they didn't follow through. They didn't go through all of those antimicrobials and all of those diseases. So what happened? Number of deaths are more and more in these regions. And when we go to the 70%, now these areas, as you can see, deaths, total number of deaths, if there are 100, 70 of them are because of infection, because of many reasons. It can be because of uh, no education whatsoever. It can be because of no availability of doctors. It can be because of no availability of antimicrobials. It can be because of low sensitivity to those antimicrobials, or it can be because of escalating antimicrobial resistance. It can be any one of those reasons. But as you see at this area, this has been subjected to death because of infection more than any other area we see, because these are not the areas which followed through the sanitations. These are not the areas which followed through all of those parameters, all of those preventive measures that scientists and doctors presented to avoid infection, or if they have gotten that infection, how to stop that infection. They couldn't follow through. And that's why they're suffering because of these infectious diseases the most. Next on, we have strategy. So, what's the strategy? We have to know what the local epidemiology of the disease is. Local epidemiology mean what's the local occurrence of that diseases? What's the cause of that diseases? What's causing that disease? We have to know what are the basic factors that are promoting that disease. And that has to be done locally, because in every region there's a very different setback, or there's a very different reason of that microorganism to be prevalent. So we have to know the local epidemiology. Next on, we'll go for differential diagnosis. What is differential diagnosis? You all know, we, on the basis of those signs and on the basis of those symptoms, come up to differential diagnosis. It's just like if a patient presents to you and says, okay, doctor, I have a fever, I have rigors and chills, and they're basically occurring at night, and I have these high plateau of fevers, and then it goes down. So I don't know what it is. So you cannot say for sure that it's either malaria or typhoid or dengue. What you do know is that on the basis of that history, maybe you will exclude dengue out, but you won't be able to exclude typhoid and malaria, or any one of them, or you cannot get to the point. So you will be like, either it's malaria, either it's typhoid, either it's illness without any cause, or we don't know of it yet. So what we'll go for? We'll go for testing. We'll go for testing. We'll go for malaria parasite. We'll go for typhoid. All of those tests, all of those differential tests, which will help us in pinpointing our diagnosis. Once we know that it's malaria, once we know it's typhoid, what we do? We're gonna go for proper treatment plans. For example, if the patient has gotten malaria, we're going to ask that patient to not sleep outside. We're going to ask that patient to use the nets. We're going to tell that patient all those preventive measures. Why? Because secondary infection can happen. Malaria is not a disease for which your antibiotics will already be ready and they will kill the whole organism. No, it will happen again and again and again. So what we do know is that we have to stop that patient from getting the secondary infection, from getting the same infection again. So once we have done that, what we're going to do, we're going to tell that patient all of those sanitary measures, all of those dietary measures that can help the patient in getting better. And then we're going to go for the treatment plans. What are the treatment plans? We're going to give that patient a specific amount of antimicrobials, a specific amount of antibiotics created for that group of diseases. Once we are done that, we're going to ask the patient and reassure the patient that if or in any way that patient misses one dose of the drug, it's all in vain. Maybe that patient will get better eventually. But if we ask the patient, if the doctor asks the patient that you have to take those antibiotics for 2 days, for 5 days, and patient takes it for 3 days, okay, patient will be better because those microbes are still there, but they have gone into the dormant stage, and then they will uh, be resistant to that antimicrobial. So, what we have to reassure is to that patient that you have to take these medications, you have to take these medications in doses, and you have to do all of those preventive measures that we talked about. Once you have done all of that, the global burden of the disease will go down because all of these are very essentials for controlling these infectious diseases, because that's what happened with smallpox. What happened? We knew why is it happening. We knew the organisms which were responsible for causing smallpox. We created their vaccines, and then we told people to stay away from that person who is already suffering from the disease so it won't spread. After going through it again and again and again, after going through the local epidemiologies and then differential diagnosis and then proper treatment plans, the global burden of that disease went down. Millions and millions of deaths per year went to literally 1 to 10 deaths per year now. So that's how we approach this kind of disease. So, in order to provide a certain plan for a certain disease or for a certain microbe, we have to understand the microbiota or those organisms. So, what we do know is that some have infectious etiology, some don't have infectious etiology. We have to learn each and every one of them individually, so that you can devise plans for them on individual basis rather than on cumulative basis. So, when to consider an infectious etiology? Now, that's a question. When will you say that, okay, this disease might be due to some kind of infection? What are those symptoms? What are those signs? What are those elements that will push you towards thinking that it's an infectious etiology? First of all, you're going to start with history. So, let me tell you that being a good doctor, you have to be very good and very thorough at your history. If you have been taking history for so long, maybe you will not be going for the lab tests. Maybe you won't say the patient to go for this laboratory test and then you'll go for the final diagnosis. Maybe you won't even go into the differentials if you're very good at history taking. Because history tells you a lot. History tells you about everything. If history won't help you in pinpointing the diagnosis, at least it will help you in developing the 2 to 3 differentials, and that, with further assistance of laboratory test, will lead to your final diagnosis. So, in approach to the patient, what we have to know is that we have to have a very good history. In that, we need to have exposure, we need to have history, we need to have host specific factors. So, we are going to start with what? Exposure, history. So, first of all, we're going to ask the patient about his name, about his whole data, that what's his name, what's his age, because many of the infectious diseases depend upon the age. Many of the infectious diseases depend upon the sex. So we're going to talk about his gender, we're going to talk about his age, we're going to talk about all of his personal data. If it's a female, we're going to talk about its periods. If it's a male, we're going to talk about if he's mature now, if if he's above 18 now, above 15 now. All of those factors are very much important in getting to our diagnosis. Then we're going to talk about the disease. We're going to talk about the symptoms of the disease. In those symptoms, we're going to talk about when did those symptoms start, what symptoms are happening right now, and have the symptoms gotten worse or better with time, and what other factors are involved in getting those symptoms. So you're going to talk about all of those presenting complaints. You're going to go very deep into those presenting complaints. And after that, you're going to go into his past medical history, his past surgical history. Then we're going to go into social history and travel history. Why social and travel history? Travel history, why travel history is important. Maybe that patient went to Africa and came back with a Congo. How will you know that patient is suffering from Congo if you don't ask for the travel history, if you don't know that he went to Africa? What about social history? What if a patient presents to you and asks that, okay, doctor, I'm having these convulsions, or I'm having these problems or panic attacks or something like that, and that patient seems kind of addicted to you, to some drugs. If you don't ask for the social history, how would you know that how his company is or her company is? Next on, we're going to talk about history of infections, exposure to drug resistance microbes. When I go deep into that history of the patient, we just talked about, we're going to ask about all of those details. And when we're done with them, what we have in our mind, what antimicrobial we have in our mind, we're going to talk about it with the patient. That has that patient ever used those antibiotics or not? And maybe he did use those antibiotics, did use those antimicrobials, and didn't complete the whole schedule, didn't complete the whole 5 day of regimen. Or some people also may come to you and say that, okay, doctor, I use this medicine, but it doesn't work on me. So before you prescribe any kind of antibiotic, antimicrobial, you have to ask the patient, have that patient or has that patient used those antimicrobials before or not? And what was the effect of them? And did he completely use the whole regimen? Next on, we're going to talk about dietary habits and specific pathogens which are involved in those diets. For example, a patient comes to you right after 10 to 15 days of eating meat, and that meat was not properly cooked, and it was of a cow. You will definitely know that that patient has some kind of parasites lurking around in his intestine. So dietary habits are very important. You're going to ask, what have you been eating for the last 1 month, or at least 15 days, or at least 7 days? Those points are very important in getting to the diagnosis that we want. So dietary habits, we're going to talk about the dietary habits of that patient. And next on, we're going to talk about animal exposures in case of ticks and mites. A patient comes to you and says, I have severe itching in my whole body. Now, what will you think of? Let's refer it to dermatologist? No. You're going to take all of the history. And at the end, when you ask about this animal exposure, and that patient will go like, yes, I have my cat, and maybe I got these ticks or mites from that. So this animal exposure is even very important. So what we learned in exposure history is that we're going to talk about all kind of exposures. And all kind of exposures mean where that patient went, where that patient goes every day. We're going to talk about that social history. Next, I'm going to talk about the history of infectious exposure. That were you exposed to some kind of person who has already been suffering from that disease? Next, I'm going to talk about its dietary habits. That what have you been eating for the last 1 month or 15 days or 7 days, depending upon the differential you have in your mind. Next on, we're going to talk about animal exposure. That what kind of animal are you exposed to? Is it animal vaccinated? Is it animal clean or not? So we're going to talk about all of this exposure history. Next on, when we're done with all of that history of the patient, once we're done with all of the prolonged history of the patient in which we asked for his personal history, his social history, his travel history, his exposure to ticks, his exposure to mites, his exposure to diets, when we're done with all of that, what we go for the examination of the patient. Examination will further narrow down your differentials. If after history it's 5 or 6 differentials, after the examination it will be 2 to 3 differentials. So first of all, we check for vital sign. We check for lymphatics. In vital signs, you'll check for all of that: heart rate, temperature. You'll check for respiratory rate. You'll check for all of the vital signs. And in those vital signs, if infection is active, what you'll see: raised temperature, maybe raised cardiac output, maybe raised respiratory rate or depressed respiratory rate, depending on which kind of pathology are we dealing with. We'll have lymphatic problems. Next on, we'll go for skin examination of the patient. We'll examine the skin, whether it's swollen, whether it's red, whether it's bruises, whether it's because of any dermatological infection. Next on, we're gonna go for examination of the foreign bodies. We'll check if the patient has already ingested or have any foreign bodies on the skin or inside the body. We'll check for all of that and approach to the patient firstly. Next on, we're going to go for diagnostic testing. Once you're done with the history, once you're done with your examinations, in examinations you also go for a lot of other things. It's not like you only go for vital signs, it's not like you only go for lymphatics. You go for the blood pressure, you go for the eyes, you go for the nose, you go for the throat. What will you look in eyes? It will be congestion, redness of the eyes, or if it's because of any pathology of the eye, basically, you'll go for that. Next one, you look for nose, you look for throat. In many infections like tonsillitis or pharyngitis, viral infections, you have to go and look for the throat. You go for throat examination. Next on, you go for your examinations of the glands. Next on, you go for the examination of your abdomen. So you go and examine that patient thoroughly in order to narrow down your differentials. Once you have narrowed down your differentials, once you have made up your mind, okay, it's either this disease, or this disease, you go for what? Diagnostic testing. When you go for diagnostic testing, we go for WBC count and inflammatory markers. We go for analysis of cerebrospinal fluid. We go for cultures and pathogen specific testing. We go for radiology. Now, let's get into the detail of these diagnostic testing, the approach we are going to have for these diagnostic testings. First of all, we're going to go for complete blood picture. In that complete blood picture, when we see increased WBCs, what happens in an infection? Body reacts, WBCs goes up. In some infections, it goes down even. In some pathological conditions, it is even repressed. But in most of the infections, WBCs goes up and inflammatory markers are present. Once we have narrowed down that, okay, it's an infection, it's an active infection, body is being infected, what we go for? We go for analysis of cerebrospinal fluid. Now, this is a rather drastic step. This depends from a practitioner to practitioner, that what he goes for next. If it was up to me, I would go for cultures and pathogen-specific testing. Then I will go for analysis of cerebrospinal fluid. But then again, it depends upon the history of the patient. It depends upon the examination of the patient. Maybe that patient is having rigid neck. You will definitely go for analysis of cerebrospinal fluid. You won't wait for cultures and specificity and radiology to come in. You will go for this. So it totally depends. The approach with which you go for these diagnostic testing totally depends upon whether your history was suggestive of this kind of disease or not. Whether your examination was suggestive of this kind of disease or not. Maybe in some diseases, you won't even go for radiology. You will be definite. Maybe just like pharyngitis or tonsillitis or in any kind of other infection, you won't even go for radiology. It's not like it's a pet pattern. You have to go for all 4 of these. No, it's not a pet pattern. You have to adapt according to your history, according to your examination. So after WBC counting and inflammatory markers, we know that there's an active infection inside the body. What we go for? We go for cultures of the patient. We take the blood, we grow it into cultures so that we can specify the pathogen. Once we have specified the pathogen, we go for the antibiotics or antimicrobials that are produced for that kind of microbe. If we're still not sure about it here and we have this rigid neck, we go for analysis of cerebrospinal fluid. That will tell us if there's any active infection there or any active pathology there. And if it's not even suggestive of that, what we go for? We go for etiology. We check for CT, MRI, X-ray, whatever suits us. For example, there's an infection or like pneumonia of your lungs. We have to go for X-ray at least so that we can pinpoint that which lobes are being affected, which kind of pneumonia it is. It is lobar pneumonia or it's not. So radiology helps us finding the pinpoint diagnosis in some cases, but not in all the cases. So all of these diagnostic testings depend upon your history and your examination, and then you have to know that which way you're going to move. That from here you're going to move where, whether you're going to move to cerebrospinal fluid, whether you're directly going to move to radiology. But these four diagnostic testings are very important in pinpointing any kind of diagnosis. Next on, approach to the patient. Now, let's talk about causes of relative bradycardia. What is bradycardia? Decreased heart rate. Now, we are just developing a mindset for you. We are just developing a mindset for you in order of telling you that, okay, we have relative bradycardia. What do you suspect? So what we have as infectious causes is that gram-negative bacteria can cause bradycardia. What else? Tick-borne organisms can cause bradycardia. What else? C. diphtheria can cause bradycardia. And what next? And some viruses can cause bradycardia. Now, these are the infectious causes of bradycardia. So whenever you are taking history of the patient and you're very sure that it's an infection, now what will narrow it down? I told you that after the history, examination will narrow it down. You go for the examination of the patient and the patient has bradycardia. What do you suspect? You know that it's an infection, and now you know that we're going for the examination and the patient has bradycardia. You have gone to these four differentials now. It's either gram-negative bacteria, either it's tick-borne organism, either C. diphtheria, or viruses. So you will go for further and further management. You'll go for further testing. You'll order those diagnostic tests which will assure us that what kind of disease are we suffering from, and then go from there to the treatment plans. Now, these are the organs involved. These are the organisms that involve those organs. What kind of exposure leads to these organisms getting in, and what happens to the eosinophilia? What's eosinophilia? Eosinophils, when are markedly increased, it's indicative of any kind of active infection in the body. So CNS, if centrally involved, which organisms do involve? Angio, strangulus, and gnathostoma. Now these are organisms that affect the CNS centrally. And what kind of exposure? Raw seafood, raw poultry, and seafood respectively. Now, so this what we're talking about, that's in exposure history, we talked about that we're going to talk about that patient and we're going to talk to that patient, but what kind of social history that person has. Where does he live? What does he do? Now, all of those questions will be very important here. Patient comes to you with infection, with sickness, and you ask, what do you do? And he goes for that, I work in a poultry farm, or I work at a sea view. So you immediately go and ask, did you eat any kind of seafood which was raw? Or did you eat any kind of poultry which was raw? Or did you eat any kind of seafood which was raw? So if the patient says yes, you obviously go into these organisms and start the treatment accordingly. So that's how social history is important to us. And what happens to the eosinophilia? When you go for complete blood count and you look for eosinophilia, it's mild, moderate to extreme respectively. It can be mild, it can be moderate, and it can be extreme depending upon the severity of the disease. But it also depends upon these exposures. If it's raw seafood, it's rather mild. But seafood raw, it's going to be extreme. Next on, we have some infections which will infect the bladder. And which organisms infect the bladder? They are schistosoma, hematobium. Now, this is the organism which affects and infects the bladder. Specifically, what kind of exposure brings that organisms in? Freshwater swimming. When you are swimming in fresh water, this organism can make its way into the bladder and cause this kind of infection. And this causes moderate and acute condition. It's moderate eosinophilia, and in chronic condition, it's just mild. You won't even know that infection is there. So, in the whole scenario of this, what will tell you that patient is suffering from this microorganism? Yes, again that social history, again that background history. That did you go for swimming? What have you been doing for last 1 month? What have you been eating for last 1 month? So freshwater swimming will definitely pick your mind and take you to this organism. Next on, we have infections which affect the muscles. And what organisms above all stands there? Trinchinella. Now, what kind of exposure is required for Trinchinella to get inside the system? Pork. That's why most of the European countries suffer from this disease. Most of the Muslim countries won't even suffer from this disease because they don't eat pork. So they are exempt of this disease, kind of. But those European countries, when they eat pork and it's not properly cooked, and in some cases it's properly cooked, but it's still there, this organism can make its way inside your body and infect your muscles and cause pathogenesis of it. And in this, moderate to extreme levels of eosinophilia is present. Now, what other organ? Let's talk about lymphatics. Which microorganism infect the lymphatics? Now, Wucheria bancrofti and Bartonella hanseli. Now, these are the two organisms which infect your lymphatics. And how do they get there? They get there through insect bites and cats, respectively. So, again, social history is very important. We talked about pet history. That have your cat bitten you? No or yes? Or has it scratched you? Or have you been subjected to any kind of insect bites? Now, these bites can induce these two organisms and they can infect the lymphatics. And in this condition, again, moderate to severe level of eosinophilia is present. Next on, WBC count. We have been talking about eosinophilia. We have been talking about WBC count in our diagnostic testing slide. So WBC count is very important to us in measuring the level of infectivity an organism has inside our body. So infectious causes of eosinophilia are, in the eye, it's gonna be loa, which causes moderate to mild eosinophilia. It can be oncochera, onco is sirsa, someone pronunciate it. They can cause also mild to moderate eosinophilia. In the liver, on the other hand, we have S. japonicum and Mansoni. It's Streptococcus and Mansoni. And they cause, again, moderate level of eosinophilia in acute levels and mild in the chronic levels. And we have fasciola, which causes what? Moderate eosinophilia. And then we have this Clonorchis and Opisthorchis. Yes, these names are difficult, but these do cause all of this. And this also causes mild to moderate level of eosinophilia. Now, these are the different organisms, and this is different kind of outcome in the WBC terms. That okay, if this loa is going to infect your eyes or is going to infect your body, it's going to result into mild to moderate level of eosinophilia. Now, this won't give off much. Help in narrowing your differentials, but you have to still know that different organisms causes different kind of response in your body, even in terms of the eosinophils. Now, inflammatory markers. When your body is infected or infested with some kind of microorganisms, inflammatory markers are released and high ESR. What is ESR? Element sedimentation rate. So high ESR is produced. That's also suggestive of what? Infection. In infectious diseases, subacute bacterial endocarditis. It's just an example of those infectious diseases. We can have abscesses. We can have urinary tract infection. We can have osteomyelitis. And we can have tuberculosis. So you went for your testing, you had these 4 to 5 differentials in your mind. Patient presented to you with symptoms like I have burning micturition. You go for testing and you find high ESR, that means it's UTI. Your history already suggested you of UTI, but still you went for diagnostic testing. Why? Because you had to be sure about it, because it's not any other cause. Or you went for some kind of maybe the patient was suffering from subacute bacterial endocarditis, it had this high ESR, but history helped you that okay, it has subacute bacterial endocarditis, but it's also suffering from urinary tract infection. So basically, high ESR levels, just like we talked about eosinophils, that in these conditions, eosinophil is going to be mild to moderate. In these conditions, it's going to be moderate to severe. Now, in terms of ESR, these 5 conditions are very important. Whenever you will have very high ESR, you have to have these differentials. Maybe you didn't even ask the patient for any kind of history. Maybe the patient is under endocarditis, you didn't have time to ask for history or go for history, and you look at the lab reports and see very high ESR. What you think in your mind that this patient is either suffering from subacute bacterial endocarditis, or suffering from abscesses, or suffering from UTI, or suffering from osteomyelitis or tuberculosis. Now, what will help you now? History and examination will help you in pinpointing your diagnosis. Next on, causes of high ESR. In cases of inflammation and inflammatory, we have giant cell arthritis, we have rheumatoid arthritis, we have systemic lupus erythematosus, which is called SLE. R stands for rheumatoid arthritis, sorry. Next on, we have malignancies in which we have high ESR. In malignancies, we have multiple myelomas and leukemias. We have lymphomas and carcinomas. Next on, in other forms, we have drug hypersensitivity reactions, ischemic tissue injury and trauma, and renal diseases. Now, these are all the causes of ESR, high ESR. We talked about 5 basic pathologies in terms of infection. In terms of infection, we talked about those 5 pathologies that, okay, you have high ESR and the patient is suggestive of infection, of infective background, you go for those 5 differentials. But what if we have inflammation? What if we have malignancies? Or what other conditions do have high ESR? So that's where this slide comes in. That if it's inflammatory, it can be giant cell arthritis, it can be rheumatoid arthritis, it can be systemic lupus erythematosus, which is basically an autoimmune disease. Then in malignancies, patient is suffering from lymphomas, leukemias, or carcinomas. What other include drug hypersensitivity reactions. Patient took some drug and had this hypersensitivity reaction. Patient will have high ESR levels. Next on, there's an ischemia of the tissue or injury or trauma like myocardial ischemia, or there's any renal diseases involved that will also lead to high ESR. Next on, we talked about going for CSF review, right? In our slide for different kind of testing we go for, diagnostic testing we go for, we talked about CSF. Now, CSF is a very good indicator of many diseases, and it helps us in narrowing our differential. So, typical CSF profile, typical cerebrospinal fluid profile, how will it look like in the cases of bacterial meningitis? All of those meningitis cases which are happening because of bacteria. Meningitis means inflammation of the meninges, and it's very crucial, very crucial pathology. Patient is on the verge of death and life. And how do we know that it's bacterial? How do we know that we have to go for certain antibiotics? How do we know that we have to go for certain cultures to identify that organism and then start treating that organism so that we can treat this bacterial meningitis? What will it look like? This typical CSF profile that we're talking about regarding bacterial meningitis. So the WBC count per microliter will be differential of WBC. It will be more than 1,000, right? And it will be more and more of PMNs, more than 80%, even in some cases more than 80%. So if you have this kind of WBC profile of that patient in the CSF, you will definitely think of bacteria. Next on, we go for glucose and protein. We check for these substances at milligram per deciliter. So, less than 40 glucose or more than 100 protein are suggestive of bacterial meningitis. Next on, we go for opening pressure, which is learned in millimeter of mercury and gram stain. In this, there's always more than 300 millimeter of water, sorry, not mercury, water, and positive gram stain in more than 60% cases. Now, this is a slide or this is a typical CSF profile that you look for in ordering to either confirm your diagnosis of bacterial meningitis or exclude your diagnosis of bacterial meningitis. Maybe that patient has more than 40 glucose or less than 100 proteins or less than 1000 WBCs or less than 300. So you'll think, no, it's not fitting up to that profile. It's not fitting up to that criteria that we talked about for bacterial meningitis. So you will be done with that. That okay, bacterial meningitis is not an option. Let's go for the viral ones. Let's go for the other causes of meningitis. So that's how you know that whether the patient is suffering from bacterial meningitis or not. Now let's talk about viral meningitis. We talked about bacterial meningitis. We looked at its typical CSF profile and we said that okay, if a patient presents to you and these are the facts, these are the stats, we always say it's bacterial. But what if, and then we talked about what if it's not up to that mark? What if it's not up to that criteria? What we go for? We go for the other diagnosis, which is viral meningitis. In this, WBC count per microliter is going to be more than 1000. Just like that. Let me revise it back to you. It also had more than 1000 WBC count. So, it has the same criteria of WBCs or differentials of WBC will be predominantly lymphocytes. In that, it was monocytes. In this, it's lymphocytes. Next on, gram stain cause, it will be negative. In that, we had positive gram stain for more than 60% of the cases. And in this, we have negative. And we had different kind of WBCs. And next on, the glucose will be normal. We talked about the glucose level of the bacterial meningitis. We talked about it's going to be more than what? Let me revise it back to you. More than 20 and less than 40 glucose. Right? It's not going to be zero glucose. Keep that in mind. It's not going to be zero glucose. Maybe a patient is suffering from very high stage of the disease, maybe less than 20, but it's going to be between 20 and 40. So if it's less than 40, it's abnormal and it's bacterial. And if it's more than 40 and it's between normal levels, it's going to be what? Viral meningitis. And it has 20 to 80 proteins. Right? So what's different? What's the difference between viral and bacterial meningitis? Where does the difference lie? Where will you pinpoint that it's bacterial or it's viral? Let me tell you, first of all, you go for glucose. In bacterial meningitis, glucose levels will be depleted. And in viral meningitis, glucose levels will be the same. Why? Because bacteria are using that glucose for their own use. That's why they are depleted. You'll go for protein levels. You'll go for the gram stains. That will differentiate it. And then you'll go for differentials of WBC, that which kind of WBC is more or in predominant nature. Next on, we have fungal meningitis. What will be the typical profile looking like here? Right? We have basically three reasons of meningitis. We have seen the profile of bacterial meningitis. We have seen the profile of viral meningitis. Now, if it's not viral, if it's not bacterial, how will we know that it's fungal? So, in fungal meningitis, what we see is 40 to 600 WBCs, not more than 1000. In that, we had more than 1000. Both of them, we had more than 1000. And rarely positive gram stain. In bacterial meningitis, it was positive in 60% cases. In viral meningitis, it was mostly negative. And in this fungal meningitis, maybe positive in some cases. So, it's not a diagnostic point for us. Yes, these WBCs are, but this is not a diagnostic point for us. This is not the point where we can actually decide that what is the pathology behind it. Next on, low to normal glucose. Now, glucose was depleted in what? Bacterial meningitis. Glucose is normal in viral meningitis. But low to normal glucose, that means fungal meningitis. Maybe it's using up to some extent, but maybe it's not. So it's low to normal glucose, 150 to 300 proteins. Now, regarding that protein levels from 150 to 300 proteins, we talked about that in viral meningitis is going to be 80 or less than 80. We talked about in bacterial meningitis it was above 100. But 150 to 300 is a typical feature of fungal meningitis. Next on we have lymphocytes or PMNs differentials of WBCs. Now it can contain lymphocytes, it can also contains PMNs. So both of them can be found inside of this fungal meningitis. Next on we have 160 to 340 opening pressure millimeter of mercury, millimeter of water. Sorry. So it's rather different from the first one, bacterial meningitis. We talked about it's going to be very different. So it's also a diagnostic point for fungal meningitis. So what's there to differentiate fungal meningitis from bacterial and viral? Number of WBCs, glucose levels, protein levels, types of cells present, and opening pressure. So all of these are very much predictive and kind of telling you that it's fungal meningitis. Now, it was just an example. This meningitis, this showing you slides of different kind of meningitis was just an example for you to how to approach those diagnostic tools, how to approach the patient regarding the history, regarding the examination, regarding the different kind of tests we performed like CSF. So this was just an example to give you so that you can keep in mind that how you approach a patient. If it's meningitis, you go for CSF examination. Which kind of meningitis? How to fix it in different forms? How to fix it in different kind of modalities? How to tick some box and confirm that this is a pinpoint diagnosis. So once you're done with all of that, once you have diagnosed a patient after a thorough history, after exposure history, after examinations, after your diagnostic tools, after your testings, after your radiological exposures, once you're done with that, we go for the treatment. Now in the treatment, we go for the antibiotic treatment if we have antibiotics for that kind of microorganism. For example, if it's an streptococcus infection, staphylococcus infection, we go for antibiotics which specifically target those infections. So we give antibiotics according to the microorganism that is infecting the body. Next on, IV immunoglobulin G. Maybe in some cases, infection persists. Some patients who are immunocompromised, some patients who are taking steroids are already immunocompromised. So they are not going to respond well to the antibiotic treatment. They are not going to respond in time to the antibiotic treatment. So what we do, we give IV intravenously immunoglobulin G. We give them already produced immunoglobulins to fight off that infection. And then we have hyperimmunoglobulins, globulins, which can also be given in some cases to fight off that kind of infection. Now, disease consult. In infection control, how to control that infection, we have to consult the disease. But in what forms or in what conditions? If it's a difficult diagnosis and those patients which are presumed infectious are going to go through that. Next on, those who are not responding to treatment as expected. Next on, those with complex medical history. And next on, we have patients who are suffering from exotic diseases. Now they will go for the disease consult. Those who are not responding to treatment as expected. For example, we thought that this antibiotic is very much suitable for this microorganism and patient will be all right, but patient is not getting all right. Maybe patient is not sensitive to that. Maybe patient has developed resistance to that. That organism has developed resistance to that kind of antibiotic. So we go for disease consult. Those with complex medical history. Now maybe a patient is suffering from rabies, while that patient is suffering from diabetes, while that patient is suffering from other medical conditions, and it's a very tough case. It's a very complex case. You go for the disease consult. And patient who are suffering from exotic diseases also go for the disease consult. So that's all for how we manage the infections, how we manage these infectious diseases. We have to develop our thinking, we have to develop our approaches. And once you have developed this approach that you're going to start from microorganism, that what by developing this mindset that what microorganisms are, how do they work, how do they cause a disease, the pathophysiology that you will learn in pathology section. Afterwards, how do we approach the patient? How do we manage the patient? We start from history taking, we go for the examinations, we go for our tools, which are diagnostic tools. We narrow down our differentials up to 2 to 3 differentials, and then we go for specific radiological testing or blood testing or CSF testing, and then we finally reach a diagnosis, and then we treat the patient with antibiotics, we treat the patient with immunoglobulins, we treat the patient with hyperimmunoglobulins. Once we are done that, even then patient is not responding. Either they're suffering from exotic disease, either they're suffering from some kind of complex medical history, or they're not responding well, we go for disease consult, and then we manage the disease according to the circumstances provided by that patient, provided by that organism which is causing that disease. So once we are very thorough with our approach to the management of the disease, it's not very difficult. So that's all for today. That's all for the management of the disease. Thank you for watching sqadia.com.